Hello, welcome to topic 3. Here we're going to talk about inflammation and healing, as well as disorders of immunity. If you need a little background review, you may want to review a little bit from chapter 15 on immunity. However, I will tell you that it goes into excessive detail that you will not need to know for this class. So I guess as you're going along through the slides, if there's something that we cover on the review that you don't understand, go back to your textbook and look. But don't spend a lot of time learning the details from chapter 15. Okay, so let's get started. Okay, you want to look at the learning objectives that we're going to cover. I just want to point out a few things. You will want to know what the difference between nonspecific and specific defenses are. You will want to describe the process or the stages of vascular and cellular responses to acute inflammation. Only briefly understand what complement, clotting, and kinin systems are, and then fairly briefly as well understand the roles of inflammatory cells that are listed there, and only very briefly describe the chemical roles of things such as histamine, leukotrienes, prostaglandins, and thromboxanes. Cytokines is a big category, so just essentially just know that it's a chemical mediator of inflammation. Okay, let's go ahead and take a look at our defense mechanisms. We have two general categories: innate defenses or nonspecific defenses. These are the things that you are born with. And adaptive immunity or specific defenses, these are things that you acquire after exposure to an antigen. Nonspecific defenses include physical barriers such as skin and mucous membranes, protective chemicals such as the acidic condition of the stomach or the enzymes in the lacrimal fluid that will destroy bacteria. It also includes cells that mediate various responses that are all innate or nonspecific. So phagocytes, including macrophages, granulocytes, other granulocytes, and dendritic cells. Natural killer cells that act nonspecifically to destroy pathogens. And then we have basophils and mast cells. They can release chemical mediators such as histamine that result in inflammation. Inflammation is also a nonspecific defense, and we'll talk about that next. Interferons that interfere with viral replication, and then complement proteins that are found in the blood that can increase inflammation, help antibodies be more effective, as well as lead to the lyse of bacteria. So all these innate defenses do not distinguish between threats. Okay, they're not antigen specific. Adaptive immunity, however, is antigen specific, and it's mediated by kind of two arms: the antibody mediated, and this is through the B lymphocytes, or cell mediated, and this is through the T lymphocytes. Once again, these are specific and they protect against specific antigens. If you have time, you'll want to check out this fun video of body defense mechanisms. You'll have to use a link once again actually from the PowerPoint slides rather than the screencast. Okay, let's talk about acute inflammation. This is the early response of tissues and blood vessels to injury. This is going to kind of isolate the area. It can be triggered by infectious organisms, immune reactions, injury due to trauma or chemical agents, or tissue necrosis. The function of inflammation, though, is to help remove or neutralize harmful agents and initiate healing. It's also going to help to limit tissue damage to the surrounding tissue. It's going to help isolate that area. And it's going to stimulate the adaptive arm of the immune response. There is an animation here on inflammation if you want to see a pictorial version of the process. So let's look at the local response to acute inflammation. We have two phases, the vascular stage and the cellular stage. The vascular stage is an immediate response. We start with a transient vasoconstriction followed by the release of chemical mediators such as histamine, which then cause vasodilation. So arterioles and venules, they dilate, and this is going to dramatically increase the blood flow to the injured area. This is going to result in the localized signs of redness and warmth. The capillaries also become more permeable, and this is going to allow protein-rich exudate to leak out of the capillaries and into the tissue spaces. This is going to result in swelling or edema. And also this excess fluid can put pressure on nerves leading to pain. Additionally, chemical mediators such as bradykinin also can trigger pain. The cellular stage is the next part, and this is divided into phases. First, we have margination or pavementing of white blood cells. So as all that fluid leaks out of the bloodstream, it's going to cause the blood to be more thick, and these white blood cells are going to move more slowly, and they're going to kind of roll along the endothelium here. Okay, and then they will be attracted by chemotaxis, that's by chemical mediators, to the area, and they will squeeze through via diapedesis or transmigration of junctions between endothelial cells in the endothelium. So they'll get out of the blood supply, and then they'll move by a chemotaxis towards the chemical mediators in areas of damage. And then these white blood cells will engulf and degrade cellular debris and pathogens by phagocytosis. The first to be mobilized are neutrophils, but they can't handle the harsh environment for very long, so they're not as long lasting. Second to arrive are the macrophages, and they are much longer lasting. Okay, so what are some of the chemical mediators of inflammation? We have things that are found in the plasma-derived mediators, the kinin system, which includes bradykinin, and these promote vasodilation and increase capillary permeability and pain. And then we have the fibrinolytic system, and this is going to promote clotting, and this is going to help to start the stage for healing. And then we have the complement system, which is also plasma-derived, and these are a collection of about 20 proteins that can come together and trigger different events. So they're going to stimulate the release of other chemical mediators, they're going to promote inflammation, they promote chemotaxis, and they're going to enhance phagocytosis. Okay, next we have the cell-derived mediators of inflammation. We have histamine that's stored and released from granules that are found in circulating basophils, as well as mast cells. So remember, basophils differentiate into mast cells in the tissue. So basophils in the blood, mast cells in the tissues. So they have these granules, and they release histamine and other chemical mediators. And histamine is going to cause vasodilation of arterioles, and that's going to lead to that increased blood flow. It's also going to lead to increased vascular permeability, which is going to allow exudate to leak out. Histamine, though, can also cause bronchoconstriction in the lungs and pruritus or itching. Those are cell-derived. And then there are some that can be produced from membrane lipids. So injured tissues and inflammatory mediators act on cell membrane phospholipids to produce arachidonic acid. And then from arachidonic acid, we can produce leukotrienes, and they're kind of involved in a late inflammatory response. They cause constriction of the pulmonary airways, so bronchoconstriction, and they increase capillary permeability. Okay, so they're going to allow things to leak out. They are also involved in chemotaxis. Then we have the prostaglandins, and they induce vasodilation and bronchoconstriction. And prostaglandins also potentiate the effect of histamine. Potentiate meaning increase its effect. Thromboxane A2 is involved in vasoconstriction. It also causes bronchoconstriction in the airway, and it promotes platelet function, which will help in platelet aggregation and blood clotting. You can see on this figure it also has where some medications work. So corticosteroid medications, they block the production of arachidonic acid. Therefore, they would block production of all the eicosanoids, leukotrienes, prostaglandins, and thromboxanes. Aspirin and NSAIDs are going to block just the cyclooxygenase pathway, which would block the production of prostaglandins and thromboxane. Okay, we also have cytokines, and I mentioned that there are so many, and you certainly do not need to know them all. But you should know that these can be produced by a variety of cell types. These are chemical mediators, and the two major ones involved in inflammation I'm just going to mention, and that's IL-1, interleukin-1, and TNF-alpha, tumor necrosis factor alpha. And they are secreted in response to bacterial toxins, immune cells, and injury. And part of what they do is they induce expression of adhesion molecules. That's going to help with that margination of the white blood cells. They're also going to release cytokines and chemokines to attract other immune cells to the area. TNF-alpha is also responsible for the acute phase response, or the systemic responses of like fever, anorexia, hypotension, and so forth that we can see with inflammation. Okay, so what are the 5 local manifestations of acute inflammation? Heat and redness. Remember that was due to increased vasodilation of the capillaries. And then swelling and pain and loss of function are all due to the increased capillary permeability, allowing exudate to leak out, that protein-rich exudate. That's going to cause the swelling. That extra fluid can impinge on nerves and lead to pain, as well as the bradykinins. And then that swelling of the tissue is going to lead to loss of function. And this can probably be a good thing. For instance, if you sprain your ankle really bad, you should rest it. So loss of function can be good. Okay, exudative fluids. So these are those fluids that can leak out during an acute inflammatory response. And there's a variety. If you just know essentially what they are, that's sufficient. So a serous exudate is clear and watery. Hemorrhagic is bloody. Fibrinous, it has a lot of fibrin. Purulent or pus, that has white blood cells. And that's due to bacterial or fungal infection. An abscess is a necrotic core filled with that purulent exudate, surrounded by neutrophils. And an ulceration is a site where the epithelial surface has become necrotic and eroded. Systemic manifestations of inflammation include a mild fever, and remember that's induced by those cytokines that we mentioned, like TNF-alpha. Leukocytosis, that refers to an increased production and circulation of white blood cells, and this is particularly true for the neutrophils. So the neutrophils really increase in number at the start of an inflammatory process. Malaise is just kind of a feeling of unwell, fatigue, headache, and anorexia. And then we also see increased production and circulation of plasma proteins. Some of the signs of this is that we can see an increase in the erythrocyte sedimentation rate. And that is the rate at which the red blood cells sediment in an hour. And this is just a non-specific measure of inflammation. C-reactive protein is another measure of non-specific inflammation. So when that increases, we see that. And that is an acute phase plasma protein that's synthesized in the liver in response to cytokines. And then we can see various cell enzymes that can get released from necrotic cells, and they enter the tissue and body fluid, and then we can measure them. For instance, in a heart attack, cardiac enzymes get released from necrotic cells, and then we can see that we have a cardiac isoform of LDH in the blood, and then that gives us an idea of where the site of inflammation is. So what are the outcomes of an acute inflammatory response? We can have one of the following. Resolution. That's just where the tissues return to normal structure and function. If the offending agent is not removed, this can cause chronic inflammation. Or if the damage is really extensive or occurs in types of tissues that don't regenerate, such as cardiac myocytes, then we can have scarring and fibrosis. Chronic inflammation. Chronic inflammation can be caused when acute inflammation is not eradicated, when the cause of it is not eradicated. Chronic inflammation occurs in various inflammatory disorders, such as rheumatoid arthritis. It's also common when we have chronic irritation, like due to smoking or bacteria, or an abnormal immune response. When we compare chronic inflammation with acute inflammation, we find less swelling and exudate with chronic inflammation, but there are more white blood cells, and more fibroblasts, and more tissue destruction, and more scar tissue. A granulomatous lesion, this refers to a mass of macrophages surrounded by lymphocytes. And this is associated with foreign bodies, such as microorganism and TB. The macrophages can clump and form a multinucleated giant cell that surrounds or attempts to surround the foreign agent. Eventually, connective tissue can encapsulate that, forming this lesion. Okay, what kind of healing can we have? Types of healing. Resolution. Resolution is where the injured cells recover and go back to the normal structure function. This can only occur if there's minimal damage. Okay, so the cells can recover. Regeneration occurs when damaged tissue gets replaced with the same kind of cells, but this can only occur in cells that are capable of division. And then replacement. This occurs when damage is extensive in tissues that are capable of dividing, or in tissues that are not capable of dividing. Then the damage does not even need to be extensive, such as cardiac muscle or neurons. With replacement, functional tissue gets replaced by scar tissue, and that's going to result in a loss of function. Fibrous tissue repair. Fibrous scar tissue can sometimes occur, leading to various complications. One is a loss of function. We can lose the normal cells in specialized structures. So like with a heart attack, we don't have those contractile cardiac cells, so we lose some of the functioning of the heart. It can cause contractures or obstructions. Contractures can restrict the range of movement. Obstructions can block passages. We could get adhesions between neighboring tissues. This especially occurs like in the intestines. If they're scarred, then they can adhere to each other, and that can cause problems with bowel movement. And then a keloid, shown here, is when we have overgrowth of scar tissue. Please take a few moments to look over the concept check questions, as well as read the test your knowledge questions and the following answer. Okay. Another test your knowledge. And answer. I'll go ahead and read this one. Okay. If you get a paper cut, epithelial tissue will be replaced with connective tissue. What do you think? Okay. And the answer is going to be false. All right, because epithelial tissue has the ability to regenerate, and the damage has not been extensive with a paper cut. Okay. Following a heart attack, the area of a heart muscle that has undergone necrosis because of a lack of blood supply undergoes healing by replacement of scar tissue. How will it function? How will compare the functioning of heart muscle that has been replaced with scar tissue with that of normal surrounding heart muscle? And of course, it's not going to function as well because scar tissue is not contractile. Okay, so now we're going to talk about immunity. Once again, you don't have to know a lot about the immune system. We could definitely spend a year talking about it. But you should know these basic things. What an antigen is, self and non-self antigens. Knowing the difference between humoral and cellular immunity. You should be able to describe the major cells and mediators of the immune response. The different classes of antibodies. And then a big one is knowing the difference between active and passive immunity and the theory behind vaccine technology. So let's talk about adaptive immunity. So adaptive immunity, this is what you acquire. Okay, you're not born with it. And adaptive immunity attacks specific microbes referred to as antigens. It develops after exposure to that specific antigen. That's why we give vaccines, okay, because we want to acquire that immunity. The mechanisms include humoral immunity, referring to the body humors or body fluids, and this is mediated by the B cells. And this functions to eliminate extracellular microbes and microbial toxins in the extracellular fluid. So the B cells differentiate into plasma cells, which release antibodies, and then those antibodies bind to antigens, forming these complexes that can lead to either precipitation out, agglutination or clumping of like cells together, or neutralization of that antigen. It can lead to lysis and destruction of the pathogens. It can facilitate phagocytosis by phagocytic cells, and it can activate complement. Cell-mediated immunity is T-cell mediated, and it functions against microbes that replicate inside body cells. It also functions to help protect us against cancer. T-cells have to accomplish double recognition. It has to recognize both body tissues or body cells and a foreign antigen. So both self and non-self antigens. So what are antigens? So self antigens are HLA proteins that label cells as self. The immune system ignores self cells normally. Non-self antigens, the immune system recognizes foreign as foreign or non-self, and the immune system produces an inflammatory response against that antigen. So it's recognized by receptors on the immune cells and by antibodies made in response to those antigens. We get memory cells that are then produced to respond quickly to that foreign antigen. So antigens can be found on bacteria, fungi, viruses, protozoas, parasites, and so forth. Now, non-microbial agents such as plant pollens, insects venom, transplanted organs can also act as antigens, and these result in what we refer to as hypersensitivity reactions, and we'll talk about these a little bit later. Okay, so let's look at the different types of immune cells. We have T helper cells. These help to coordinate the immune response. So helper cells are going to activate both B and T cells. The cytotoxic T cells, also called killer Ts, they attack infected or virally infected or cancerous body cells. The T suppressor, these are regulatory cells that control the immune response. They're going to inhibit the self-reactive lymphocytes so that we don't cause too much damage to self-tissues. B cells, once again, differentiate into the antibody-secreting plasma cells, as well as memory cells that stay in the body for a long period of time. Antigen-presenting cells, these are things like macrophages and dendritic cells, or these are phagocytic cells that gobble up the antigen and then present them to other white blood cells. And then other white blood cells such as phagocytes and NK cells can release various mediators promoting inflammation or activating other immune cells. Okay, let's talk about antibodies or immunoglobulins. There are 5 different classes. IgGs, these are the most common in the blood, and this is the only antibodies that cross the placenta. IgA, these are the most predominant antibody found in body secretions, such as tears, saliva or mucus secretions, also found in colostrum. IgM, these antibodies form in response to the blood AB antigens. They're also the first to increase in an early immune response in the blood. IgE, these bind to mast cells and basophils. These are involved in parasitic infections. And as we'll see later, they are involved in allergic and hypersensitivity reactions. And not a lot is known about IgDs. Let's not worry about those. Okay, let's talk about the difference between a primary and secondary immune response. So primary immune response is the first time that the body's been exposed to that antigen. So we get exposed to the antigen, and then there is a lag time, and then we have a primary immune response about roughly 4 weeks after exposure to the antigen, where we get our full amount of antibodies that we're going to produce. Okay, so we have our activated B cell. During this time, we haven't produced a lot of antibodies, and it took a while. So we get sick. However, we could provide that first immune response by giving a vaccination so that we have protection. Because what happens after we are exposed, either by getting sick or by getting a vaccination, is we create these memory cells. So that the next time that we are exposed to the antigen, these memory cells are activated immediately, and the plasma antibody levels rise to a much greater extent and much quicker within days. Okay, so in the case of being exposed to something, maybe we wouldn't get sick because we have this secondary response so quickly. Another example of producing a secondary response is giving a booster shot. Okay, let's talk about active and passive immunity. So active immunity results when the body fights off an antigen, and then it develops memory. With active immunity, you have to fight off you have to be exposed to the antigen. You can acquire this naturally from having the illness, or artificially from being vaccinated. Passive immunity results when the body is not exposed to the antigen. Therefore, it doesn't develop memory, but it does receive protection by getting antibodies from another body. This can occur naturally from a mother to an infant via breast milk, or from a mother to a fetus via the placenta. It can also occur artificially by receiving injected antibodies for illnesses such as hepatitis or rabies or tetanus. Passive immunity does not last nearly as long because the protection ends when the antibodies degrade. Let's go back to that other slide. See these antibodies? Antibodies degrade over time. But active immunity lasts much longer because the memory cells that are created when exposed to the antigen last for decades. Okay, go ahead and take a look at the concept check and make sure you can answer those questions. Okay, let's talk about this discussion, active versus passive immunity. So a woman who recently has a baby said that her immunity went to her baby and that the baby will not need any vaccinations. Is this correct? Well, let's think about it for a minute. Did the baby get the immunity from her mother? Well, the baby got antibodies from the mother. Both before birth and then if she was breastfeeding in that colostrum. Remember, those antibodies degrade over a period of time. So the baby will need vaccinations because the baby only acquired passive immunity, which is not long-lasting. So the baby will need vaccinations in order to acquire active immunity. So tell whether the following statement is true or false. A vaccination is an example of adaptive immunity. And that's true. It is a form of adaptive, and I will say adactive immunity. Okay, tell whether the following statement is true or false. Active immunity is achieved much quicker than passive immunity. Okay, and that's going to be false. Because with active immunity, you're exposed to an antigen and that starts the immune response. Antibodies get formed in a period of time. With passive immunity, you're given the antibodies right away and you don't have to wait for them to be produced. Okay, I'm going to stop there. In the next screencast, we'll start disorders of immunity.